are aware of either have a family member, friend, or someone that you know who suffers with bipolar disorder. Okay. Do you know if it's bipolar 1 or 2?
I didn't
2.
know the difference.
And so you're going to learn something before we get down to the first 15 minutes. Okay, so mostly 2. Okay. I think 2 is underdiagnosed. Okay, for a lot of reasons, and we'll look at that. Bipolar disorder is often misdiagnosed, undiagnosed, diagnosed incorrectly, and you're going to see why it's hard to do it. And you're probably going to see some people. You're probably going to see some things and think, I think so and so is that. Okay, that happens in the psychology. You see things and go, I think that's so and so. Well, you're going to see some information I think that will make you lean that way. All right. 3 words are underlined, are bolded and in a different color print. Bipolar disorder is common, severe, and persistent mental illness. The one thing about bipolar, hard to deal with as personalities. Different people are there on different days, and you don't know what to expect. It's just kind of out of the box. And that's why, if you're a person who is interacting at a normal level of functioning, and you're interacting with a person who has a bipolar disorder, you're not going to be able to receive everything they're saying to you and feel good about it. Okay, now bipolar is characterized by periods of deep, prolonged, and profound depression that alternate with periods of an excessively elevated or irritable mood known as mania. Okay, between the highs and lows, they actually can function pretty well or even function very well. A lot of famous people in history may have been bipolar. Because when you're bipolar and you're on your energy level high, you are more productive. You get more things done. You see possibilities. And I don't know if that's kind of like opening the mind in some way with that disease, but they are very energetic. They get a lot of stuff done, very creative. You could not keep up with them. But there's other times where you don't really care anything about being around them. Okay, go another direction. Okay. It's a mood spectrum disorder. Okay, so we have, and so I'm going to put it in rank with everything we talked about. Major depression, major depressive disorder we talked about. That's part of the mood spectrum. Bipolar 2 is milder disease. Bipolar 1 is the classic manic depression person, and cyclothymia is oscillating between high and low moods. Okay, here's this picture I think is very helpful. Okay, between these 2 dark lines with the dotted line, this is like even keel, emotionally. And then there's a range, even in the normal, if you don't have a psychiatric diagnosis, you still have good times and bad times. So you have good times, and we're in a bad time right now, and we come back to a good time, but things will cycle. That's just what life is. Okay, on the low end, as you move to a lower mood, then you're into a subsyndromal depression, then major depression. The lower limit of normal mood is sadness or grief. Okay, we talked about grief reactions versus full-blown depression. So once you go below normal grief, you get into major depression symptoms. On the high side, there's a phase called hypomania. This is what you see in bipolar 2, where it's kind of like higher functioning, more energy. We'll look at the symptoms. And then you move to mania, which is something else. Okay? So you've got a range.
Is there a time scale on that? Like, just generally speaking?
No, well, let me, I've got another picture that will kind of highlight it. But let me tell you, this is just very symmetrical and kind of pretty in colors for us to look at. But this cycle thing can be very stretched out. It can be very tight. It can be very wide. You can stay on the low end for a long time and come up higher. So it can be a lot of things. Okay, I'm going to show you something here. We'll get to it. Okay, pathophysiology. We don't know why. Okay, I'm saying a bunch in this class. We don't know why exactly. There's no biological markers yet, but there are some structural defects. There are problems with the cortical, limbic, basal ganglia, and cerebellar structures. You know when I showed you that picture of mania, those SPECT scans, there was some, it didn't light up the same way, it wasn't functioning in the same way. So there's something going on structurally wrong. There's also identified defects in mitochondrial energy production in the brain. So energy production is not consistently the same or done well. And there are other events that happen in that brain. Electron transport chain, I don't know if y'all talked about it or not. Have y'all talked about G protein coupled receptor signaling? I know Dr. Tess has brought that up. You know when a drug binds to a receptor, whatever it is, that's not the end of things, that's the beginning of things. The chemical lands on the receptor and then that activates a whole series of protein interactions inside that cell to actually eventually do something, you know, make something, contract, do whatever. So there's something wrong with the coupling of, it's probably neurotransmitters, the monoamines bind in the brain, but something happens beyond that binding that is not correct. So there's a defect in the way neurotransmitters can function in that person's brain because of the defect. And we just don't quite know all of what that is. Okay, there is genetic research. Twins and family studies indicate a genetic component. So if you have a bipolar member of your family, you probably will be looking for potentials in others who are produced, you know, within that family. First-degree relatives are approximately 7 times more likely to develop bipolar disease than the rest of the population. So that says something right there. Epidemiology is a common 1 to 1.6% lifelong prevalence. That's a whole lot less than depression by a good bit. Morbidity and mortality. Again, you get lost productivity. They give you numbers. They give you suicide attempts 25 to 50%. And you know, in depression, it was higher, like 50 to 75% could be. And then race, there's no racial predisposition that exists. Bipolar 1 occurs equally in the sexes. That's the full-blown mania. Bipolar 2 is more frequent in women. Rapid cycling bipolar disease, 4 more episodes in a year, more common in women. You were talking about how rapid that thing go. It can go, shoot, 4 times in a year is just what defines rapid cycling. You can cycle more than 4 times in a year. And just can you imagine the havoc in a household with somebody who was up and down multiple times in the year. Age, onset anywhere from childhood to 50 years old. That's real helpful. So if you have in your family, you've been watching somebody for a long time. Mean age of onset, though, is 21 years. That's pretty typical. Most cases start around 15 to 19, with the second most frequent being age 20 to 24. I know of an individual, have a friend, and they're concerned that their child might actually have this. And the child is like, you know, early teen, kind of teenage years. And in the family tree, there is bipolar illness that is still present. And so this parent is watching. Just because, you know, there's just anything that's not quite right, they're, I think, hyper attuned to it. Okay, bipolar 1 disorder. Okay, here's the DSM-5 characteristics for that. To have a diagnosis of bipolar 1, you have to have at least 1 manic episode during a lifetime. That's it. You have to be manic once. If you're manic once, you're bipolar 1 for the rest of your life. Okay? The manic episode may have been preceded by and may be followed by hypomanic or major depressive episodes. The major depressive episodes are common in bipolar 1. So if you have mania, you see a lot of people also have major depression, it is not required for the diagnosis. So to be diagnosed bipolar 1, you have to have mania. And there are people who are bipolar 1 who have only had mania and never had depression, though you commonly see depression and mania. It wouldn't rule it out. So it's not required for the diagnosis. Bipolar 1 requires at least a 1 week, you gotta have 1 week period of abnormally and persistently elevated, expansive or irritable mood, and abnormally and persistently increased goal-directed activity or energy. So to have bipolar 1, you have to have 1 week of mania, and that is at least abnormally, persistently elevated, expansive or irritable mood, and abnormally, persistently increased goal-directed activity or energy. The mood disturbance is sufficiently severe, and this is like everything in DSM-5, to cause marked impairment in social or occupational functioning, or to necessitate hospitalization, or there are psychotic features. So the way you look at it, you're going to have the person that's, life is going to be disrupted. Let me just say that. If they're at work or they're at home, life is going to be disrupted. Something's going to be going haywire. They may be hospitalized because it's so severe they're afraid they're going to hurt somebody or themselves. They can kill somebody in a manic phase. That's not unusual in the newspaper to read what's going on. Or there are psychotic features, which means they have hallucinations, delusions, those types of things. They have to have, in addition to those two things, you know, the 1 week of the elevated mood and the increased energy and purposeful activity, 3 or more of the following symptoms are present. 4 if the mood is only irritable. So if mood is just irritable but not expansive and all elated, then you have to have one more symptom. We call it mania. But here they are. Inflated self-esteem or grandiosity. These people are important. They are better than you and they know stuff. They can do stuff. Decreased need for sleep. More talkative than usual or pressure to keep talking. Flight of ideas or subjective experience of thoughts are racing. Easily distractible. Increase in goal-directed activity, either socially at work or school or sexually, or psychomotor agitation. These people are hypersexual, and very often you'll see affairs happening with people in the manic phase. Excessive involvement in activities that have a high potential for painful consequences. Shopping sprees where they blow up your credit card to the roof. Sexual indiscretions, one-night stands, or foolish business investment. Classic is get on a plane, fly to Las Vegas, find anybody you find staying up all night, gamble all your money away, have a big old time, and then come down and go, oops, what did I do? And that's kind of the picture. The episode is, here's the disclaimers, the episode is not attributed to physiological effects of a substance or another medical condition. You can't take methamphetamine and have these symptoms and call it mania. They're just abuse of methamphetamine. They're addicted. If all of the above are present, the patient has a manic episode. Now, watch this. I love it. See how much of her we can get.
Anderson. At MD Anderson, we're making cancer history. At MD Anderson, we're making cancer history.
Well, Mary, I'm glad you could come back. Can you say how you're feeling this morning?
Oh, on top of the world.
Okay.
On top of the world.
What are your plans for today?
Oh, it's just going to be one great day.
What are you going to do?
Well, whatever my doctor says I can do, I should say that right now.
Oh, suck it up.
Tell me a little bit about that. You mean you may have some restrictions?
Yeah, still.
Uh-huh.
I went off with my husband last night. I beat him up.
What? No. Tell me about that.
Well, I wanted him out of there.
He came to visit?
Yeah, he came to visit me.
Okay.
And he pissed me off, so I wanted him out of there, so I beat him up.
What do you mean you beat him up?
I forcibly beat him up.
You hit him?
Quite a few times. Oh, yeah, slugging it out.
You were saying something earlier about Jesus Christ and the CIA.
Okay, I'm in incognito for the Lord, God Almighty, Jesus Christ.
Mm-hmm.
Okay, I'm working for Him. I have been for years.
And what do you mean incognito?
I'm a spy.
And what's your mission?
My mission is to fight the American way.
Can you say more about it?
The Statue of Liberty.
Okay. But I mean, can you talk more
It's all
about the
wrapped
kinds of
up.
things that you have to do or have been doing as part of that mission?
Oh, I can bring up the wind, I can bring the rain, I can bring the sunshine,
Delusion of
I can
grandeur.
do lots of things through Christ who strengthens me.
Okay. I mean, you can actually cause the wind to come up.
Oh, yes.
Could you do that today if you wanted
Sure,
to?
oh, yeah.
And what gives you the power to do that?
God.
Prayers.
On our walk down, you were mentioning about the air and the smells, and we saw some flowers. You like the outdoors?
I love the outdoors. It's my favorite place to be is outdoors. Well, see, when I first met my husband, can I just talk?
Sure, please.
When I first met my husband, we lived underneath a bridge and down at a boat dock. We weren't married.
Mhm.
But I believe we got married in the eyes of God down at this boat dock
Mhm.
because he popped my cherry and I had been married.
When we first sat down, we asked if you could take your gum out, and you had some strong feelings about that.
I've chewed since I was a little bitty kid. Don't hurt my teeth or nothing. I got strong teeth and I like hard gum. I like to blow bubbles with it.
Okay. Is that a good piece?
Yeah, it's a real good piece. Want a piece?
No, thanks. So, talk a little bit more about the way that sometimes you start crying. I mean, what's the sort of thing that can get you crying?
Missing my mom for one.
Okay.
She died. I told you that my mom died.
I think so.
April 5th, 1993.
Uh-huh.
My mother passed away.
What happened?
Well, she hadn't walked for 21 years of my life.
Mhm.
Am I still focused? Okay.
She's talking to the camera.
That's not funny, then. Am I still focused? Okay, anyway. Back to seriousness. Okay. She had cancer of the spinal cord when I was 11 years old.
Mhm.
And they had to take out her backbone, 8 inches of her backbone out, to kill the cancerous tumor.
Mhm.
So that means she was paralyzed from her breast down
Mhm.
for 21 years of her life. She died the age of the year I was born, 61.
Mhm.
I believe everything has a purpose under
Yeah,
heaven.
yeah. What do you make of that?
I believe that's the time that God wrote down she was going to die. Before she hit her 62nd birthday, she was going to die and be my guardian angel at 61 of the year I was born.
You mentioned the other day that drinking coffee, something happens to you.
I get drunk on it.
Let's say something about that.
I can get drunk on coffee. I can get drunk on water. I can get drunk on Kool-Aid. I can get drunk on lots of things.
Now, can you get drunk on those things at all times or only at certain times?
When I'm high.
When you're having one of these up
Yeah.
periods? Are there times when being up like this is unpleasant?
It always feels good. Never feels unpleasant at all. Except for when I can't go to sleep because of it.
Mm-hmm.
When I'm too up and I cannot sleep.
Mm-hmm.
That's the only bad part about it.
How did you sleep last night?
Not worth a damn.
Not good.
No.
How many hours?
I didn't sleep at all. I just rested.
Even though you didn't sleep last night, you still have good energy?
Oh, yeah.
Do you feel as good as if you had gotten a full night's rest?
Oh, yeah. Big time.
Okay. Were you able this morning, feeling this good, were you able to concentrate on things that you wanted to
Yeah.
concentrate on?
Sure was. I have to put some stuff away. I folded laundry. I
Okay.
stuck socks together.
Okay. Do you think that if you were outside the hospital right now, you'd be able to do all the things that you needed to do?
Oh, yeah.
Sometimes when you're feeling this good, do you go out and do things that get you into some kind of trouble?
Oh, sure.
Like what?
Mess around with my husband.
Okay. And it gets you into trouble?
Big time.
Yeah.
And the voices, my gosh, can I hear the voices?
Talk about the voices.
It's what's around me, like up at the front desk. People outside my window, I can hear them all.
Now, are these voices of people that you can't see?
Right.
Okay. What kinds of things are they saying?
Well, that's none of my business, really.
Is there anything else that you want to mention?
Yes, I'm a morphodite.
Yes, talk about that. You mentioned that to me one time.
Okay. I'm a male and a female mixed.
Okay.
I have both organs. And I believe that that's where God is up in heaven.
Okay. Mary, I want to thank you for coming back, because we've covered a lot of things.
Yeah.
Okay. Thanks again.
Right.
Okay.
And cut.
And cut.
Okay, so did you see, we saw everything, she was everything, she's manic, she's bipolar 1, that's mania. She had psychotic features, she had energy, she was hypersexual, she had that elated big mood, she did stuff, she had all the activity. So that's what a manic person can look like. Ever seen anybody like that? Okay, something else. Okay. Let's see how this thing usually runs. Course of bipolar disorder. The onset age at first, at onset of the first manic, hypomanic, or major depressive episode is 18 years of age. However, it can be really late, even as late as 50s and 60s and 70s, which I think is kind of unusual. More than 90% of patients who have a single manic episode go on to have recurrent mood episodes. So to have one and be done is not the usual pattern. 50%, approximately 60% of manic episodes occur immediately before a major depressive episode. So they're way up here, way up here, way up here, and then they're way down there. But 40% are not. Individuals with bipolar who have multiple mood episodes within 1 year receive the specifier with rapid cycling. And I just put that down because y'all really haven't gotten into specifiers and modifiers, but when you're coding for billing purposes, you will, like I told you yesterday, you will always put down a diagnosis, and then there's numbers for that, and then there's other numbers you can add on. They're called modifiers, and they specify some things. So this person, you could code this person as bipolar 1 with rapid cycling, and that's the way the diagnosis would be put down. Here's the one I was thinking about for you. Okay, here's just the course of a bipolar disorder. Euthymia is what's referred to when your mood is in the middle range, okay? Doing okay. Then this person had depression, and then they became manic, had a mania phase of mania. Then they come down to subsyndromal depression, which kind of rocks along, kind of normal, a little bit below, kind of normal. Then they bottom out again. Then they come back up to hypomania, and then they move out. And we're going to talk about hypomania here in a minute. But so this person had everything. Normal, depressed, mania, subsyndromal for quite a while, then depression. So it's a long phase of being kind of down, then a little blip up on hypomania, then back down. So you can see almost anything is possible. They can be depressed, 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 manic, normal, depressed. So it can be a lot of things. Let's look at bipolar 2. What is that? Okay. Okay, for a diagnosis of bipolar 2 disorder, it's necessary to meet the criteria for at least one current or past hypomanic episode. So it doesn't even have to be an episode of mania, it's a hypomania, and the criteria for at least one current or past major depressive episode. There cannot ever have been a diagnosis of a manic episode. So if you have mania one time, you're bipolar 1. It's over by diagnosis. If you have hypomania once and you have a major depressive episode, then you have bipolar 2. So they're hypomanic and depressed, have to have those in their lifetime to have the diagnosis. Never, as soon as they have a manic episode, they are something else. Okay? Bipolar 2 disorder is similar to bipolar 1 disorder, except the patient experiences an episode of hypomania rather than mania. The patient must experience a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity of energy. So there's that mood and energy and lasts at least 4 consecutive days. So what was it for mania? It was 7 days. And for hypomania, it's 4 days. You almost wonder how they get it down to that range, but that's it. But it also tells you that hypomania may not last that long. You may kind of have it for a couple of days, and then you come back into the euthymic phase. 3 of the following must be present in addition to that energy and mood thing that's hypomania. 4 of these are present if the mood is only irritable. So it's the same things, self-esteem issues, grandiosity, decreased need for sleep, more talkative, flight of ideals or subjective experience, the thoughts are raising, distractible, increase in goals, directed activity, excessive involvement in activities or high potential for painful consequences. Okay. The change is uncharacteristic of the individual when not symptomatic, so there definitely has to be a change off the baseline. The episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. If there are psychotic features, the episode is by definition manic. So if they say they hear voices or see things, they're manic, they're no longer, there's no way they can be bipolar 2, they're bipolar 1. But here's why it's kind of hard to figure it out. They might have all this energy and mood expansion, but it's not enough to cause marked impairment. So they might just look like the person with all the energy in the office area. It's like, my gosh, that person can do a ton of work. I think hypomania gets under called because it's not so bad that relationships are blown up, but it's just a level of functioning that's a little bit higher than what most people are doing. The mean onset for the first mood episode of bipolar 2 is mid-20s, so again, same thing. The illness most often begins with a depressive episode and is not recognized as bipolar 2 disorder until a hypomanic episode occurs. You'll see this. The first thing will be a major depressive episode. They'll be given the diagnostic code for major depressive episode, and they might be depressed again, and they might be depressed again, and then one day they're hypomanic and now their diagnosis is no longer major depressive disorder, it's bipolar 2. So it's possible that the diagnosis can change as their life unfolds. You have to be sure that anxiety, substance use, or eating disorders, anxiety, substance use, or eating disorders may also precede the diagnosis, complicating detection. Many experience several episodes of depression prior to that first hypomanic episode. Okay. The number of lifetime mood episodes tends to be higher for bipolar 2 than for major depressive disorder or bipolar 1. They tend to cycle around a good bit. The interval between mood episodes tends to decrease with increasing age. So the older they get, the tighter it is. It can change from high to low more quickly. While hypomanic episodes define the diagnosis of bipolar 2, the major depressive episodes are more enduring and disabling over time. So it's depression that gets them more so than the hypomanic part of their functioning. Despite the dominance of depression, once a hypomanic episode occurs, the diagnosis is bipolar 2 and never reverts to major depressive disorder again. Okay. 5 to 15% of patients with bipolar 2 disorder have multiple mood episodes within the previous 12 months. And this pattern is known as rapid cycle. So 4 or more cycles within a year is how you come up with rapid cycling. Switching from a depressive episode to a manic or hypomanic episode may occur both spontaneously and during treatment for depression. This is something you're going to have to remember, and I'm sure Dr. Tessie will emphasize it also. A lot of the medications we use for depression, they are increasing the amount of monoamines in the synapses in the brain. By nature, they're elevating those monoamines. What if they elevate them a little bit too much for you and you lose regulation to the point that you now have hypomania? So you'll see people talking about they were receiving drug therapy that precipitated a hypomanic episode. Well, that's what it is. You're trying to regulate mood. Maybe you don't hit the mark every time. And so there is that risk. About 15% of individuals with bipolar 2 will ultimately develop a manic episode, which changes the diagnosis of bipolar 1 disorder regardless of subsequent course. So to have bipolar 1, you have mania, that's it. Major depression, if that's all you've ever had, it stays major depression. The minute you get hypomania with depression, you have bipolar 2, and if you ever have manic, then it gets converted up to bipolar 1. It kind of makes sense. You just have to know what the elements are. What's the difference? Just one more time to look at it. Mania and hypomania duration. Mania must exist for 1 week. Hypomania must exist for at least 4 days. And honestly, if you have enough symptoms and it goes out to a week, then you may be looking at mania. So it depends on the presentation and timing. Mania is more severe, and the consequences, manic episode causes more impairment, more serious consequences. You know, those risky behaviors, even hospitalizations, lose a job, and that can happen in the middle of it. Misdiagnosing bipolar. The diagnosis is often missed. Patients often fail to mention the presence of manic or more commonly hypomanic symptoms in a past or current episode. It's because the hyperfunctioning is not so far out of the realm of possibility that it's believable, so that people won't really consider themselves. They might tell you, I used to really get a lot of stuff done at work, but not anymore. Well, maybe that phase was really hypomania all along, but they don't call it because it's not so much as to impair them all the time. 40% of patients, let me go here, for screening for bipolar in patients presenting with depressive symptoms is seldom conducted, so you might be missing things. 40% of patients diagnosed with depression are subsequently found to have bipolar disorders. Okay. Average of 8 years from the time of first presentation until correct diagnosis in patients with bipolar disease. So you just have to have enough history on somebody to actually know what their disorder really is. Consequences of misdiagnosing. Suicide risk is 25 to 50%. Suicide attempt occurs 30 times more frequently during depressive episodes than during manic or hypomanic episodes. So not knowing what they have actually delays treatment, and the treatment for bipolar 1 and 2 is very different than treatment for major depression. You'll see that. You really have to get into mood stabilization medications plus medications for depression. If you just treat depression without mood stabilization, you really don't solve that person's problem. But you'll get more details about what mood stabilizing medications there are out there. And as I already said, the use of antidepressants in bipolar depression, especially without the concomitant use of a mood stabilizer, may actually worsen the course of the disease. So accurate diagnosis is helpful. And honestly, sometimes when you treat a person for depression and you don't treat for mood disorder because you didn't call them a bipolar 2 when that's what they were, it's the fact that they go to hypomania that you have to reconsider what your diagnosis was because of your treatment outcome. So the treatment actually precipitated the other events you needed to see to actually correct the diagnosis and retreat. Antidepressants do contribute to rapid cycling. We talked about that. Oh, goodness. It's the presence of manic or hypomanic symptoms. I think we've already said these things. Okay. Here's some little points of note. Depressed patients with bipolar 2 disorder are more frequently misdiagnosed than with bipolar 1 disorder because the patient often feels well when hypomanic and may not report them even if questioned directly. The patient does not present with psychotic symptoms, therefore they're not hospitalized, so there are no records of a hypomanic episode. And the clinical presentation of patients with mild hypomania may be irritability rather than euphoria, or they may report an exaggerated sense of well-being that is often associated with an elevated mood state and not hypomania. And some people are irritable and just hypomanic and undiagnosed, and people just consider this is mean, this is the mean phase. But their mean phase might actually be a hypomanic phase. Screening for manic and hypomanic symptoms. Okay, in the folder I put on D2L, I put down several screening tools that could be used in primary care offices. And one of those screening tools was the Mood Disorder Questionnaire, the MDQ. It is a brief instrument. It just gives you some questions to help you figure out whether you have mania involved in it or not. It's one page. It's like purple at the top. You'll see it. I'll ask you to open up and just look at it on your own time. I'm not going to ask you to remember all these scoring systems, but what they do in the end is they give you some, you get answers, and then based on the answers, you get a positive screen, then you're pretty close. It says sensitivity 73% and specificity of 90% for having bipolar disorder. 5 minutes or less. So a score of 7 or more yes answers in question 1 plus yes to questions in the second section then you get moderate to serious. Just read through it. It's not critical that you remember everything about it, except that the MDQ is useful to screen for mood disorders in a primary care office and actually help you get a little bit further in assessment than you would without it, and save you some time. Interviewing a family member or other informant. You know, we talked about this yesterday, collateral informants, because when people have psychiatric disorders, they very often they're not very insightful about what to report, or they may be hiding stuff too. Or some of their behaviors are best assessed by somebody who is receiving it so they can interpret it. You know, sometimes what people do, they don't realize how they're impacting others. And then when you finally talk to other people, then they'll tell you, well, he wasn't just getting excited, he was agitated, mean, and that won't be presented by the person. The attempt to interview the patients, you want to get the spouse, parent, child, significant other, close friend. Patients may fail to recall manic or hypomanic symptoms, or may not have no insight into their impact they've had on their functioning. Many patients value their heightened activity and energy during hypomanic states and fail to report them pathologic. They actually like them. They don't want you to take them away because that's how they get stuff done. And then patients also fear the stigma attached with bipolar disorders. They don't want that diagnosis, so they won't do your mood questionnaires. They won't tell you stuff. Okay. Any questions so far about what we got? So a lot of distinction. Now you see you have to be able to call major depressive episode bipolar 2 and bipolar 1, and you have to look at the episodes and the supporting symptoms. And it may actually take you a period of 10 years even to figure out what somebody is. Okay? Kind of interesting. Let's see here. What's their appearance? In the depressive episode is what we've seen. No need to kind of repeat that. It would look typical. In the hypomanic phase, the appearance, busy, active, involved, energetic, planning, doing. Others notice the energy level and remark about them. In the manic episode, their appearance is pretty extreme, as you saw with that lady, and I'll let you you can read these on your own time. Behavior, restless, talking fast, clothes, usually go in haste or disorganized, or they're bright, colorful, garish, or hypersexual. Okay. In depressed episode, similar, we told they feel sad, lost, vacant. The two H's, helpless, hopeless, helpless. Hypomanic, moods up, manic, euphoric, elated, wild. Thought content in depressed episode, we talked about that. Thinking about suicide, worthlessness, feeling sad. Hypomanic people are optimistic, forward-thinking, positive attitude. So you wouldn't consider those to be bad features. Those might actually be good features. And then in the manic episode, the thought content's expansive, overly self-confident or grandiose. I mean, this woman could control the elements. She had it all going on. They're rapidly producing thoughts, highly distractible. See, am I still focused? Am I still in the camera? Kind of self-focused, but watching. So that's manic. Perceptions. What do people in depressed mood perceive? Delusions of having sinned are accompanied by guilt and remorse, or the patient goes utterly worthless. I told you that guilt thing. Some patients experience paranoia, persecutory delusions in a big time manic depressive episode. You could have that delusion. They don't have perception disturbances. Another reason why it may not be reported as abnormal. And then manic, 75% have delusions. Power, prestige, position, self-worth, and glory. I think that woman checks all the boxes. She had a lot of stuff going on. She was an agent of God. Her mission is to make America great again. I'm just saying, she could have said that. Okay, that's it. Moving on. Suicide and self-destruction, depressed episode. Then we have, it's common in a depressed episode. Incidence of suicide is very low in hypomanic phase, and the incidence of suicide in a manic episode is very low because they're worth everything. Why would you kill yourself? They might kill you, but where they would kill themselves. Homicide, violence, and aggression, depressive episode, suicide is the paramount issue. Some see the world as hopeless and helpless for themselves as well as others. This perspective can lead to homicide followed by suicide, and we seem to be having a bout of that, where somebody feels hopeless and they're going to take out everybody else because they don't want to leave their family behind. If I'm not going to be here, they can't be here. And I mean, literally, I think the newspaper and on the news, there is something along these lines. Some items every week, there's stuff going on. It's more common than we think and disturbing. Hypomania frequently show evidence of irritability and aggressiveness, pushy and impatient with others. Manic episode, openly combative and aggressive. She beat her husband up and she actually had bandages on her hand to prove it. No patience or tolerance for others, demanding, violently assertive, highly irritable. Homicidal element emerges if they have a delusional content to their mania. Maybe they're here as an agent from God and they're going to make this area better, and the only way it's going to be better is if you were dead. But that's part of their mission. They act out grandiose belief that others must obey their commands, wishes, and directives. That's why they're fairly demanding and irritable. If you don't do what they want you to do, they get mad in a hurry. If delusions become persecutory, they may defend themselves in a homicidal fashion. Judgment and insight in bipolar. Depressed episode, judgment's clouded and dim, all the things we've already talked about for depression. Little insight in their own behavior, which is true. Hypomania, they have good but expansive judgment. They take on too much, they get over-involved. Distractibility impairs judgment. Little insight, see themselves as productive and conscientious. And then manic, seriously impaired judgment. Terrible decisions regarding work and family. May invest family fortune in questionable funds. Become professionally over-involved in work activities. Start a series of dramatic, unsound fiscal or professional ventures. Don't listen. No insight. Often commitment proves the only way to contain them, which is why they get hospitalized. If you don't put them away, there's no telling what further harm they can cause to themselves or others or their families. I think the bad thing is if a parent has bipolar disorder, they could actually ruin you financially in one of those phases, and then your family is left with that for forever. And nobody's going to forgive you that you don't pay the rent. Somebody already bet it off in Las Vegas, and now you're stuck. And I've heard that from patients who it's like, oh my gosh, kind of scary. The differential diagnosis for bipolar disorders, obviously anxiety, Cushing syndrome, head trauma, hyper and hypothyroidism, depending on what phase they're in. You know, a manic person could be hyperthyroid, it's pretty hyped up, hypothyroid depression, PTSD, schizoaffective disorder, schizophrenia, and we'll talk about all of these later. Lupus, medications, ADHD, especially in children. So what do we do with these folks? We are. CDC for a lot of different anemia as a cause of depression. Anticonvulsants can suppress bone marrow. I know y'all went over some of that last week. Lithium, reversible increase in white blood cells. Have y'all had lithium presented yet? Was lithium presented in neurology? Where was it presented? Seizures? Cluster headaches? What else? Where else did y'all learn it? Antidepressant, well, really a mood stabilizer. Did she talk in depth about lithium, or did she tell that she was going to roll it forward to this module? I know we do big lithium here, and there's many things to think about. It's a difficult drug to use for a lot of reasons. SID rate looks for infection or lupus, fasting glucose rule out diabetes, and many of the atypical antipsychotics that are used to mood stabilize have problems with weight gain and blood sugar. And that is, you'll get this in your lectures on Thursday, you really have to remember a lot of the drugs that are used for mood stabilization and tranquilization that are available now cause a number of metabolic disorders. So you can create obesity, you can create diabetes in people who are prone to it, and you can make it worse in people who already have those issues. So the drugs are needed, but they cause stuff we don't like. Electrolytes, calcium, serum protein, Low in patients not eating may increase levels of protein-bound medications because less protein-bound. I just know these are not ordinary things you're going to look at in every patient. Thyroid study, substance and alcohol screening, copper level to rule out Wilson's disease, the ANA, HIV, BDRL for syphilis. It's just very much like we talked about working up for depression. There's so many metabolic infectious processes or toxicities that can show up with similar effects. Now treatment, this is just an overview. Referral or close consultation with the psychiatrist must be strongly considered. A primary care provider is not going to be managing a bipolar patient by themselves. I can't see it. In fact, they usually act out so much in practice that they get fired from practice. I had one lady, I know she was bipolar, and when I confronted her, she wanted me to do something for her, and she'd been referred down to OUHSC, and her request was inappropriate. And I told her it wasn't something that we could do in that clinic, and she said, well, I really need you to do that. And I said, well, it's not medically indicated and it's not safe. And then she went off into a streak of cursing me, whatever. And I told her, I don't know that we have anything we can do to offer you here. And then she got fired from the clinic because she'd been working her way up to this for a good long while. You can't do that to me. And she did get fired and she did leave. And I'm pretty sure she was a bipolar person just by her behavior. It was so, she so disrupted everything. And I remember calling up to one of her primary care providers, I think in Blackwell. When I got on the phone, I said, I want to talk to you about a patient who comes from your practice area because we're missing a lot of information that we think would be helpful. This is back in the beginning, and they said, well, which patient is that? And I gave the name, and the lady said, oh. It was that kind of knowing, oh. And from that point forward, I knew that this was a problem. I already knew it was a problem, but then it was really a problem. Okay. Drug therapy is much more complicated and entails greater risk than that of major unipolar depression. So when you just have depression, sometimes they're referred to as unipolar. It just means you're on one pole, low or normal. In bipolar, you're low and high. Polypharmacy is the rule in these patients. You will be using more than one medicine. Lithium has been the standard of treatment for decades. Anticonvulsants with mood stabilizing properties like valproic acid, that valproax, carbamazepine, and lamotrigine, all of those you've looked at, and then the atypical antipsychotics, olanzapine, risperidone, and quetiapine. All of those agents are atypical antipsychotics. Inpatient hospitalization is often required in that manic phase. Their danger to self, others are totally unable to function without loss of control. Medication monitoring is needed for safety. There are some hospitalizations that run day programs where they're hospitalized, at night, but then they can go out, and that's kind of as you try to reintegrate a person back into the world. They've gotten beyond the phase, they're beginning to stabilize, but you still don't have confidence they should be out there by themselves. So they come back, you're assured medicines are administered and taken, and then you keep going out until you're ready for discharge. Outpatient treatment, the four major goals: establish a way to manage areas of stress in life. You're always worried about stress in life of people with psychiatric disorders because they tend to precipitate more crises. Stabilize medications to achieve benefit and minimize adverse effects. That's a big deal for the long haul. Develop and maintain a therapeutic alliance. That is, you have to have a person who knows the patient, and they have to be able to get along with their provider so they stay with you. Bipolar people are very likely to shop doctors. They don't like you, so they'll go somewhere else, and they keep working. And they never actually end up anywhere because the very nature of their disease, they're just going to act out, break rules, and disappear. So it's very hard to get stable care for bipolar patients because of how they act. It's hard. Educate the patient and family about the disease and the dangers of substance abuse, relapse, role of medications, and support groups. Many bipolar patients like medications. They've used them to self-medicate. That's all we need is more neurochemistry defects on top of what's already going on, but they're very prone to it. appropriate medication depends on the phase of the disease. The doctor will tell us, we talk about acute and chronic maintenance management, and it really is, it is an ongoing management conundrum. You cannot just get the right dose and everything is done. You have to keep working with it over the long haul because the disease is not stable. It's changing all the time. Choice of agent depends on presence of symptoms such as psychotic symptoms, agitation, aggression, and sleep disturbances. Okay, prognosis. Bipolar 1 has a far worse prognosis than those with bipolar 2 or major depressive disorder. And I think you see why they're the ones who go manic and can cause problems. They may end up in jail. That's one of the problems with bipolar 1 is they do crimes when they're in a manic phase, so they may end up in jail. So if you ever end up being a PA in a prison population, and there are people who do that, you have a disproportionate number of people in prison who have bipolar disorder and personality disorders like antisocial personality. They almost always end up in prison. So you have very dangerous people in that population that are not honest with you about what they're thinking or doing. Within 2 years after initial diagnosis, 50% experience another manic attack. Factors suggesting a worse prognosis: poor job history, alcohol abuse, psychotic features, depression features between periods of mania and depression, and if you're male. Indicators for better prognosis: manic phases are short in duration, late age of onset, few thoughts of suicide, few psychotic symptoms, and few medical problems. The conclusion: very serious group of illnesses. They're associated with great morbidity and mortality, more so than unipolar depression. Treatments for unipolar depression and bipolar depression differ significantly. They are not the same treatments. And you have to consider the differential diagnosis of bipolar to be sure that you're not missing something that could be corrected and fixable that's helpful other than the disease at hand. And we're caught up. Okay. Let me talk to you for a second because we're almost done here. Any questions about this topic? Yes?
When they're just randomly in that normal phase, are they aware of how different their behavior is during?
Yeah. Insight is there. You know, this is a good question about psychiatric disorders. When they're in the quote unquote normal phase, their mood is stabilized, then they can have insight like any other person has insight. As they cycle down into a depression, you lose insight when you're very depressed. You lose insight when you're very manic. So when you go off of the norm, your insight goes down. And that's part of why once you slip a little bit, it's easier to fall way down because then you may be on medications when you're in the normal phase, but then as your brain chemistry begins to change and you begin to be a little bit more manic, you then begin to believe you have a little bit more power and control, and so I don't need these things anymore. So they stop taking medicine, then they slide down the hill further. So on either end, as you lose insight, your compliance with medication and staying in contact with healthcare providers falls apart. So then when you get them, when they're on the far end of each side, then you kind of work them all the way back, and they will know, I know I did bad things. I know I've done this. But they are really not able to control that, you know. So that's why you have to have empathy for it. But if you're a family member, it's still very difficult to live with it. You know, they may not be able to. So as insight changes, they slide deeper in, and then you may have no insight at all. Yes?
So I find it really shocking that it takes about 8 years to get the diagnosis right.
Yeah.
Do you recommend the use of mood stabilizers initially with low-dose SSRIs to try and not send them into the manic state?
Well, I think I will let Dr. Latessa get into more details about doing that. But when you're looking at somebody, but it takes 8 years to figure out whether you have bipolar because you have to have depression and a hypomanic episode. Legally and by any practice right, you're only going to respond to what you've seen. If it looks like depression, then you treat it like depression. You could do, if you had a family history, if you have a family history of bipolar disorder, then you might have an index of suspicion that that person could go there. It wouldn't make you put them on a mood stabilizer because you would treat depression like you treat depression, but you would watch. And you want to have good follow-up and maybe tell them, if you see this, if you feel this way, we want to see you again. And then at the point that they slid into something, a state that was clearly diagnosable as hypomania or mania, then you start moving into your mood stabilizer use. But to use it prophylactically in somebody based on just knowing that it may take a long time to actually see the full diagnosis, that major depressive person might just be major depressive episode for life, that's it. And so you wouldn't use medications to prevent bipolar. If you had family history and were suspicious, you'd be watching about when it would be appropriate to do it, but I think to do it, to prevent it, is problematic because they may not be that. And then your medication, your mood stabilizer medications are full of adverse effects. So you don't have the diagnosis and you're suspicious it could go this way, but you don't know it. You wouldn't put them on drugs that cost a lot that can make them sick in other ways. Okay, does that answer your question?
Yes, sir.
Okay. Other questions about bipolar? Isn't it interesting? I mean, this whole thing about mood and whatever I think is very fascinating. And I'm giving you very much the definitional big picture things. You really have to see people to get an appreciation for the range of the possibilities. So these classes really are to introduce to what's possible, and then you have to learn it for yourself by seeing it. So clearly this is the beginning, it isn't the end. And I think using medications in psychiatric patients is very hard to teach in a classroom. There are many things we can teach, and you'll know a bunch, and it'll be all good stuff. Then you have to actually work with them and people to really get a feel for how that it's done. Lots of titration up and down and working with different medication groups over time, and a lot of good documentation to figure out what will work. And the sad thing about psychiatry is you figure out something that stabilizes somebody, and it can work for 2 or 3 years, and then the 4th year it just all blows up and you can't figure anything out, and everybody gets frustrated. But that's the way it is. Okay? Any other questions? Then get out of here. Be sure to come back at 1 o'clock.